and welcome back to ADC Aspirants. Today's video is all about scenario-based questions discussion. We are going to be dealing with the topic of endodontic diagnosis and information gathering cluster. Also, a bit about pain relief medications and professional code of conduct. Now, whether you're a beginner or someone already into the process and your preparation of ADC written examination, this video is going to be helpful for you. Because in this video, we talk about how to approach scenario-based questions with the correct methodology. Enjoy this, and remember, we have such videos and such live quizzes in our written examination course every single week, in fact, twice in a week. So make sure that you reach out to us if you have any questions about our coaching for the written examination preparation. Let's start with the discussion of scenario-based questions. I'm going to be reading out the questions and also the options, and then we'll decide what is the correct answer. I want all of you to keep a pen and a paper handy or anything that helps you choose and see how many answers that you're getting correct and how are you thinking in terms of arriving at your conclusion. Ethan, a 44-year-old patient, comes to you and he has a complaint of pain on one of his upper back teeth on the left-hand side. He feels uncomfortable and annoyed due to his condition. He presented without any facial swelling, did not have any fever or difficulty in opening his mouth or difficulty in swallowing. Amongst the following, which is the most appropriate question to ask this patient to arrive at a provisional diagnosis? Number 1. On a scale of 1 to 10, how much would you rate the pain? Number 2. Does it hurt when you have hot or cold food? Number 3. Does the pain radiate to your right eye? Number 4. Did you have any swelling on the right hand side of your face? Number 5. Can you describe the pain? Now, ideally in our discussions, which we have weekly, we would give around a minute's time to all our candidates to write down their answers or present them in the chat box. However, because we are now going to be discussing this one after the other, I would like to start giving out the answers and see where and what you select. At any point, you may want to pause the video, write down your answer, and then listen to the discussion that we have. Based on this question, we know that this is a cluster of information gathering, which means that now we're just getting as much information as possible about patient's current dental status or about his current complaint, which is pain. When we talk about pain, always remember, we are going to start our questionnaire in an open-ended manner, which is not only important for our theory exams, but a very important and integral part of our OSCE communication. When you deal with open-ended questions, it gives the patient an opportunity to describe the condition or the pain that they're dealing with or the discomfort that they're dealing with. When you do not get enough information, that's when you switch to close-ended, right? So when you look at that criteria, which one falls into that category? Option A, on a scale of 1 to 10, how much would you rate the pain, is very close-ended. Option 2, does it hurt when you have hot and cold, is also a close-ended question. Does the pain radiate to your right eye? Now here the patient has come with a complaint on the left-hand side, so why are we talking about the right side? Isn't it? I'm excluding that as well. Do you have any swelling on the right side of your face? Same thing. They're talking about the current complaint of the patient to be on the left-hand side, but this option talks about the right-hand side. So you see what I do? I try to first rule out all my negative answers, and then I find out which out of these options is kind of following into the correct answer category. For me, that option is going to be option E, because first of all, it is a very good open-ended question and gives an opportunity to the patient to decide why he's here. Socrates is a very important part of our questionnaire when we are dealing with pain. Of course, most of our dental patients come with the problem of pain, right? Also, Therapeutic Guidelines, which is one of the most important books for our preparation for the written examination, tells us, ask specific questions to narrow the field, but phrase them as open-ended questions because they are more effective than close and potentially leading questions. For example, ask what particular things cause pain in your tooth rather than asking, do hot and cold drinks cause you pain? I hope this helps you understand why we're choosing E as the correct answer, and if you also chose it as the correct answer, well done. Let's move on. Now this patient says that the pain started 2 days ago while he was eating pork chop. He felt a piece of tooth chip away. The pain has since then worsened, keeping him up at night sometimes. He doesn't report pain while chewing on that side. He has taken pain control or pain relief Panadol, which is paracetamol, as and when the pain occurs, but that doesn't seem to solve his problem. Based on the symptoms above, what could be the current pulpal diagnosis? So let's look at the question first before we talk about the options. The keywords that we are trying to extract in this question are his pain status. Pain started 2 days ago, that's fine, but currently it has worsened, right? It is keeping him up at night. So now that gives us an indication of what the pulpal status may be. There is no pain on chewing on that side. Again, pulpal status still can be verified by the severity of the pain the patient has been experiencing. Pain relief or Panadol that he has taken does not seem to solve his problem. Our second hint here. So the pulpal diagnosis out of these options, which are irreversible pulpitis, reversible pulpitis, cracked tooth, vertical root fracture, and pulp necrosis, is going to be, you're right. If you've answered A, it is correct. Irreversible pulpitis. Now, irreversible pulpitis, as we all know, is an irreversible damage of the pulp, and that could be because of various reasons. To limit the discussion in this particular video, we are not going to be discussing the background of each and every choice or option that we have. However, for us to have a broad knowledge, we should know about all the options that are asked. Why not reversible pulpitis? Because the pain is now getting worse and it's not getting better even when the stimulus is removed or on taking painkillers. All right. Cracked tooth, typically the patient has pain on biting or when they release the bite. Vertical root fracture is a different entity altogether. Mostly occurs in sometimes root canal treated teeth which have had a lot of treatment done earlier, big fillings, etc. So vertical root fracture, one of the pathognomic features is also a very isolated deep pocket on one of the surfaces of the affected tooth. Pulpal necrosis, why are we ruling that out? It is a clinical diagnostic category indicating the death of the dental pulp necessitating root canal treatment. The pulp is non-responsive to pulp testing and is asymptomatic. Mostly asymptomatic, right? Here our patient is giving us direct signs of pain which is getting progressively worsened. All right. So if you've answered A, again, well done. These are a few references that we've picked up from some of the literatures out there, some of the textbooks, and this is what we present in our weekly scenario-based discussions as well. So we have an open mind. Because when you're preparing for these ADC written examination, you have to make sure that you're going through as many x-rays as possible. This is our explanation of pulpal diagnosis, what a normal pulp looks like, what reversible pulpitis looks like, what is symptomatic and asymptomatic irreversible pulpitis. So if you are someone who was only thinking of irreversible pulpitis as one entity, you must know that it can also be subdivided into symptomatic and asymptomatic. Next question. Based on the information which was provided to you, what is the current periapical status for the patient? So let me go back to the main question to help you understand. The patient had pain which was getting worse. It was keeping him up at night. It wasn't getting better when he had pain relief, but he did not have pain on biting on that side. And remember, there is no x-ray given to us. So what would your diagnosis be for the periapical status in this condition? Will it be symptomatic apical periodontitis, asymptomatic apical periodontitis, symptomatic necrosis, asymptomatic necrosis, or it could also be normal? If you're thinking the answer to be E, you're right, my friend. So it's not necessary that every time that you get a question or a scenario where, a lot of things are given and you're not able to arrive at a conclusion, there has to be a pathology. This patient may have a very normal periapical condition because the main hint or the clue given in the exam was, or in the question was, there is no pain on biting for the patient. Pain on biting could be indicative, I agree, of cracked tooth or also of apical periodontitis. And sometimes x-rays can help us differentiate, not with cracked teeth, but definitely, for our periapical conditions. But to keep it simple and clear and think logically, the answer is going to be normal periapical tissues. Let's see why. Normal apical tissues are not sensitive to percussion or palpation, and radiographically, the lamina dura surrounding the root is intact and the periodontal ligament space is also uniform. As with pulp testing, comparative testing for percussion and palpation should always begin with normal teeth as a baseline. So we don't have any X-ray, we don't have any radiographic finding. So how do we say it's normal? Just based on the symptoms of the patient. It's not necessary that all the questions in the exam are going to be crystal clear. A lot depends upon your conceptual knowledge as well. Symptomatic and asymptomatic apical periodontitis. They're both inflammation of the apical periodontium producing clinical symptoms which could be painful in symptomatic apical periodontitis to biting, percussion or palpation. Now this may or may not be associated with radiographic changes. Severe pain to percussion or palpation is highly indicative of a degenerating pulp and root canal treatment is needed. However, in asymptomatic apical periodontitis, there is inflammation and destruction of the apical periodontium that is of pulpal origin. It appears as an apical radiolucency and may not or does not present any clinical symptoms. The term asymptomatic itself dictates or projects that there is no pain on percussion or palpation. Abscess is a different entity altogether, and I highly recommend going through various resources which we provide in our academy as well. For example, textbooks, study notes, ADA guidelines, which will help you clarify your concepts more and more as in when you start preparing for these exams. Now, let's look at the next set of questions. We are moving slowly from our cluster of information gathering to the cluster of diagnosis. And what are the investigations that are needed or the initial tests to be done to confirm your diagnosis? One of the things that I would like to bring to everyone's notice, whether you're a beginner or someone who is, already started with the preparation, but you don't know where you're at, or someone who is now ready to give the exam. Make sure that in the exam, you do not miss out on these important words. These could be anything: initial, most likely, least likely, important, or something as simple as, most appropriate and least appropriate. Sometimes when we are, giving the exam in that anxious and nervous environment, we tend to just, forget, or we tend to overlook very important information which is a part of your scenario. Believe me, a lot of times candidates come back after the exam and say that I wish I had reread the paper or some questions again which I wasn't very clear about. So make sure when you're reading the question for the first time, you're reading it in a very appropriate manner and not missing out even a single clue. Coming to this question, what are the initial tests to be done to confirm your diagnosis? A. Palpation, percussion and probing. B. Percussion, palpation and IOPA. C. Electric pulp test, percussion and palpation. D. Palpation, percussion, probing and a cold test. Or E. Bitewing of the affected site, percussion, probing and a cold test. One clue or one tip that I would like to give everyone is when you're preparing for these exams, the ADC written exam, make sure that you're choosing wholesome answers which do not limit your thinking or help you, make a decision that this is something that I would do for my patient. So coming back to the question, the correct answer, I will give it to you in a second because the second part of the question is a continuation. Make sure that you write down this answer somewhere and then we'll come back to discuss it. The next part of the same question or the same scenario is what information or test is most useful to confirm the diagnosis of reversible pulpitis. Now, I remember that this patient Ethan that we're talking about had symptoms of irreversible pulpitis, but sometimes a part of a scenario may ask you a general question. So this is how your mind starts playing in the exam as well. 1 minute you're thinking of irreversible pulpitis or cracked tooth and apical periodontitis, and the other minute one of the questions asks you a very general, straightforward thing. Like, what are the things that will help you diagnose a reversible pulpitis? Options: initial onset of pain, percussion test, periapical radiograph, crack finder test, transient nature of the pain. The answer for the fourth question, first of all, let's discuss this. The initial test to be done to confirm your diagnosis is correct. If you've answered E, that's the correct answer. And why? I'll tell you. The tests are always going to be done to make sure that you arrive at your correct diagnosis, right? Now, remember this patient who came in who had pain on sleeping, etc. And, the pain was not getting better with Panadol, and we were kind of trying to arrive at a diagnosis of irreversible pulpitis. Initially, what is it that you're going to do? Because you haven't done any tests till now. Will you choose only palpation, percussion, and probing? Not a bad option, actually. Maybe I would. I would want to do the test on that tooth or the contralateral tooth and see what's going on. Let's keep that aside. Would you do a percussion, palpation, and an IOPA? Makes sense, because I want to see a radiograph where I can see what's happening around the roots, what's happening around the tooth. Is there any cavity or caries? What is the extent? And I can only understand that when I have an X-ray. So now when I compare my option B to A, the fact that it has an X-ray involved, I'm starting to incline towards this option. Option C, electric pulp test, percussion, and palpation. Wherever the option of electric pulp test comes, because literature suggests that it should not be, preferred over other tests like a cold test, I will probably keep it aside. And this is something you understand when you prepare for these exams and you read resources which give you updated knowledge and guidelines. So option C is something I'm ruling out just because it has electric pulp test and there's no option of an X-ray in that. Option D, palpation, percussion, probing, and a cold test. Now this does make sense, but where is my X-ray in this option? I'm not getting to do any X-ray, which means I cannot find out the extent of the cavity or anything else that may be going wrong with the tooth. Now, E option gives me a wholesome, answer. I know we are doing a bite wing instead of an IOPA, and IOPA would probably give me more indication of whether there's an apical periodontitis or not. But a bite wing will also help me understand what is happening with the pulpal status. I don't need to do an IOPA only to see the pulpal status. I can see that with the help of my bite wing as well. Percussion, yes. Probing, right. Cold test is the most diagnostic criteria whenever we're doing a pulp sensibility test. It's the gold standard right now, as of now, what we are doing to find out, pulpal status of teeth on a day-to-day dentistry basis. So which is why I'm choosing E as my correct answer. I understand if you all are thinking that, is this how I'm going to be, dealing with each and every question in the exam? That's going to make me lose a lot of time. Let me tell you, with regular practice, like our candidates who are with us for 6 months to 1 year, questions like these become very easy. But if you're somebody, of course, who's here only to gain an insight of how we coach for the ADC exams or how the actual preparation looks like, this may be a little difficult, to navigate initially. Now, the next question is about pain regimes and pain management in patients who present with dental conditions. Up until now, we were dealing with endodontic conditions and diagnosis and information gathering. Let's read this. The patient mentioned sleepless night, severe pain, medical history of asthma, which is controlled with an inhaler. What pain relief is the best for Ethan? Now, for all of you who are preparing for the examinations, let me tell you, for any prescriptions or any pain medications or any other medications for that matter, which have to be studied for the ADC exams, always follow therapeutic guidelines and nothing else. They have given you detailed information about the dosages, the frequency of all the medications that are relevant to general dentists that can be prescribed by general dentists in Australia. So make sure that you are very, very thorough with it. You have it on your, on your table, on your bedside, when you're traveling anywhere. all the time, so you can keep going back and forth too. And for the sake of all of you who are listening to this video, I would like to mention that we also have video recordings for therapeutic guidelines, which you can always hear or listen to, or maybe have a look at if you don't want to just read the book and you find it too boring, and that makes your TG reading very, very interesting. Coming back to our question, the pain relief options are either paracetamol 1000 milligrams and ibuprofen. So they have given us a variety of options with mixed dosages. Some of them mention ibuprofen with 400, some of them with 200, some of them with other options with oxycodone, without oxycodone. So let's see how we are arriving at a correct answer in this particular question. Let me rule out my negative answers first. Never ever prescribe fixed dose combinations of paracetamol or ibuprofen. You know how there are medications which are given which have half the strength of paracetamol and half the strength of NSAIDs, which are non-steroidal anti-inflammatory drugs. They are not effective in pain control, especially which is severe. So that's why I'm ruling out my A option. My other option is with paracetamol, which is the correct dosage, but unfortunately ibuprofen is not the correct dosage. It is supposed to be 400. So that's my wrong option there. C option does give me again a wrong dose of ibuprofen. Also, it gives me oxycodone, which is an opioid and sparingly used. TG or therapeutic guidelines does talk about using oxycodone in severe dental pain. However, not more than 3 days. But this particular option states oxycodone for 5 days, which is why I am not going to choose it as the correct option. And automatically, my option D becomes my correct answer. So it's paracetamol 1000 milligrams 4 to 6 hourly plus ibuprofen 400 milligrams 6 to 8 hourly for 3 days. Let's read a bit about this. What are the considerations regarding NSAIDs in dentistry for people who may have NSAID-induced respiratory symptoms? Any patient who has experienced worsening of respiratory symptoms like nasal congestion, runny nose, chest tightness, difficulty in breathing, after taking an NSAID, always prefer using a COX-2 selective NSAID and not ibuprofen. Avoid non-selective NSAIDs, which is ibuprofen, diclofenac, and naproxen. Prefer celecoxib. Asthma, as given in TG, is not a contraindication to NSAID use unless the patient has experienced an exacerbation after taking NSAIDs. So you see, once you're thorough with your therapeutic guidelines, arriving at your correct answers becomes an easy task. Let's see what is the next question. Again, this is a slide which talks about, where NSAIDs should not be given. And all of this information has been taken from Therapeutic Guidelines version 4, which is the most updated version, which we provide in our institute or academy as well. Let's look at some more questions about pain, I believe. This is all a part of our weekly sessions, which, we discuss. I would love to talk about this particular question because, again, it is one of the professionalism or code of conduct questions. All right. So imagine a scenario where a patient wants to save a tooth. However, it is beyond the scope of your professional competence. What does that mean? It means you are not able to perform a procedure within your skill set or your domain. And now the question says that the patient also has financial constraints. What will be your professional advice to the patient? Let's say hypothetically, the patient, or the procedure or the tooth we are talking about is this particular tooth. It has undergone root canal treatment in the past. There's post and core, there's a gold crown on top of it. The other areas have also been, crowned. But now the patient, you've seen this patient and the patient wants to save this tooth. There may be some symptoms which may indicate that the patient, may have to have it pulled out, but it is patient's wish to save it. You cannot be doing that because you may not be skilled to do a root canal treatment. What will be your professional advice? Will you, option A, tell the patient that an endodontist will be able to save the tooth by removing the fractured root or performing a procedure which will take care of the tooth? Will it be B, an endodontist will be able to evaluate if the tooth can be saved or not? C, the prognosis of that particular tooth is hopeless and the extraction is the only recommended option? D, you can charge her 50% of the endodontist's fee and try to save the tooth for her? E. To make it financially suitable, you will remove the crown and the post and refer the patient to an endodontist. Now remember, always when you're giving these exams, choose the most ideal option. Your clinical experience is not what they're asking in the exam. What they want to judge is how professional and how ethically will you be performing a particular procedure. So when you're dealing with a question like this, my straight pick for the answer would be go to an endodontist. You are not definitely giving them a solution and saying that the endodontist will be able to save your tooth. Rather, you're saying that an endodontist will be able to evaluate further with the help of their expertise and knowledge whether this tooth can be saved or not. Which is why we are referring the patient to a specialist. The correct option here is B. It is very important for me to include a part of professionalism or code of conduct, a question as well in one of the scenarios in today's discussion, because this is something I believe we have not been taught a lot when we are studying in our undergrad, but it is a very important part of your ADC examination. It is a field of dentistry, a topic of discussion, which is asked over and over again. Why do we send the patients to a specialist? You refer the patients, let's talk about an endodontist or any specialist for that matter, if the diagnosis is uncertain or if unavailable technical treatment skills and equipment are required, which in our case was true in the scenario because we were not competent to do that root canal or, to give a diagnosis whether the tooth can be saved or not. Calcified canals, pulp stones, ledges, open apices, perforations, leaking temporary restorations, root fractures, internal and external resorption, the dreaded separated instrument or other foreign objects. Now we are dealing with failures which could have led to the failure of a root canal treatment. Are you someone who is professionally competent to do that? If your question says no, then just refer. Now, this brings us to an end of the discussion for this particular video where we have discussed endodontic, aspects and also some pain relief medications and also a very small part of professional competency. I would like to tell you all this is definitely not enough. This is going to be just, I would say 1% of your entire ADC exam preparation, but this is how you need to approach scenario-based questions. Thank you for listening. Thank you for being a part of today's video. And if you've got all the answers correct, you're on the right path. All the very best to all of you.